thank you for being here this morning. I mean, it's always great to have you back.
Thank you.
And your lecture this year, has been a huge hit. In fact, I shared with the speakers. I'm sure you got the email that I have your performance reviews. So I'll be sending those out to you as soon as
looking for a raise.
As soon as the weekend's over. So basically, this is where COPE requires us to actually collect this data, and where people give feedback. And on our form, I make it so that there are very few multiple choice questions or scale questions, but then there's a big qualitative section, just like tell me whatever you want about the speaker. So I give you the
that's a little scary, I have to be honest with you, but okay.
I give you the real feedback, right, instead of just numbers. So anyway, you'll be getting that. But
before we start the formal part, tell us a little bit about SUNY and the how you managed last year as far as teaching the students, etc.
Yeah, that's a great question, Dr. Farkas. We had to go from live to essentially 100% virtual in a week's period, 10-day period. From the standpoint of the classroom, that was relatively easy because we just went to a complete virtual format. Laboratories were trickier. The hands-on laboratories became not so hands-on. So those had to be done virtually, and we left a few things over for when the students returned live. So for instance, some of the procedure type things, some of them we had to save until they came back. Some thankfully it was March, so they were pretty well along in the academic year. Obviously the big thing was the class. So we were shut down for, that was March. So I think we started ramping back up a little bit in May. We also had to take our externships into account, and those came back online at a variety of times. So essentially what we did was we took a hands-on clinical program and made it into a virtual one. Students rotated in essentially the same clinics they would have been live, but we ran cases essentially. So for instance, in my glaucoma clinic, rather than it being live, the same students plus some others, some of the externships were added on. I'd present a case. We did it a few different ways. I might present the case and have the students think through it and give me their thoughts, or they got a case and had to present it as if it was in the clinic, and we discussed it. So from the standpoint of case management, I think the students might even have gotten a little bit more. But obviously the face-to-face was much more difficult.
Right.
And in retrospect, the class of 2020, who we were most worried about because they were closest to graduation, it was probably easiest on them, although it was difficult. It was the following class, the class of 2021, the one that just graduated, who were in the third year at the time. They lost a chunk right there at the end of their third year, which I think is really a time when students grow. And now the class that was in the second year has just come forward into fourth year. And I think, we're finding that they didn't have as much experience. I don't want to say that they're at a different level. They're at different places in terms of their thinking versus their hands-on. And I think at the end of the day, what we saw last year was that the students who graduated were probably, at least based upon the evaluations of our externships and our internal faculty, about at the same place. Although I'm not sure they thought so, quite frankly.
How'd they do, Rich, on the national boards with respect to previous years? Did it affect them
Yeah,
at
that's
all?
an interesting one. Part 3 has been kind of a, I don't want to say a crapshoot, but it's been, part 3 has really been up and down, I think, for many schools, including us. But it's not much different, or wasn't much different than it's been. Our part 1 scores remain good, or part 2 scores remain good. And that kind of makes sense, because I think those exams, they probably would have more time to study for them. Mm-hmm. But the downside was it got canceled a few times. Both part 1, part 3 got canceled, and that affected them as well.
You know,
So it's been
seeing,
quite a year, to say
seeing
the
a SUNY
least.
sign brings me, you know, I'm one of the last living graduates of Columbia University.
I
don't
I
think
am
that
aware of that, actually.
I don't think anyone has left, but I recall because I'm going to ask you the question, but I got to preface it that I remember our contact lens clinic. The professor was Isidore Finkelstein, who was a very well-known person then. And our contact lens course was a scleral lens patient who had keratoconus, who was passed down from class to class. He never was cured. He always came back. So my question to you is, do you have some glaucoma patients that keep coming back for follow-up treatment year to year that the students teach? Or do you get them out of there and have new glaucoma patients?
Oh, well, I came back to SUNY. I was at the VA for 10 years after also being in private practice. I came back to SUNY in 99, and I've had patients who have been with me since 99.
Yeah.
So, based on the disease itself, you're going to see patients 3-4 times a year. So I know these patients. I've seen them probably over 100 times.
Yeah.
And it helps in education, because when you're dealing with a chronic disease, as you well know, it's important to know the person, not just the disease.
Yep.
And so the way I've always worked that with students is that we have a pre-meeting before patient care begins, and it's just as much to give them a sense of who they're going to see, as well as the case, the disease process. And I think that's so important. So, yeah, I mean, when you think of ongoing care for chronic conditions, I think that's a rich learning experience for our students,
Right.
as long as you give them that background. So, the case you saw with Dr. Finkelstein, or the case now, I think there's many similarities there.
Rich, I think I did a VT case, my first patient ever, in the early 80s. I graduated from SUNY, and I think that child is still there now in the VT department. And the record is about like this now.
Well, now it's not, because it's all electronic.
Electronic,
but
right.
I get the point. And those convergence insufficiencies take a long time.
They take a long time. Yep.
Well, there's a funny story. I saw this young woman. This is more than a decade ago. I saw her walking down the hall. I said, she looks so familiar. She's a very tall woman. She had Marfan syndrome. And I remembered I saw her as a student. So I looked back, and sure enough, 1984, there was Madonna's name on her chart, and she kind of remembered me, which was interesting as well. So, yeah. So when you're at a place for a long time, you certainly develop those relationships and so forth.
We know your wheelhouse is glaucoma, and your lectures about IOP and how it's important and not important. You want to start off by just explaining what you mean about IOP not being the end all of it, and what's going on?
Really, more specifically, the object of the course, there's kind of two objectives. One is to get doctors to think about the fact that Goldmann Tonometry, not just necessarily IOP, but Goldmann Tonometry, something that's so fundamental to what we do. And, you take it, you look at it, okay, you get a number and you move on. But I think it's important for doctors to always remember that Goldmann is not perfect. It's far from perfect. And Hans Goldmann, when he invented the tonometer in 1957, made it very clear that it's not perfect. And so I think we have to think of that single number we get and put it into the context of all of the flaws that are inherent to Goldmann, even though Goldmann's not going to go away, that's for sure. And then I guess the other objective is to recognize that there are probably better ways to measure intraocular pressure. Some of those are on the market. Some may be in the future. Some may never make it to market. But they try to get at some of these flaws that are part of Goldmann. And I guess I should add this. The other objective is to just recognize how to best use Goldmann, because that, as I say, it's not going away. Best use Goldmann in your patient care. Not thinking of that measurement of 16 as 16.00000, but recognize that there's variability in the measurement. There's diurnal fluctuation, which everybody knows. And that Goldmann, although certainly is a good predictor, a reasonably good predictor of who's going to develop glaucoma and who's going to progress, reasonably good, there are probably better things out there. So I think that's kind of the whole package when I think about why I put this course together.
And even with the fantastic IOP measurement that you may get with the various hysteresis or pachymetry and corrections, we're only attacking IOP, and there's a lot of other things involved in glaucoma.
No question.
Even vitamin B3 now and some other things, but IOP is the way we're attacking it, but it's, as you know, a neurodegenerative disease. And I would love to be able to measure, instead of Goldmann and the cerebrospinal fluid pressure, for example.
Yeah, which is, I get to very briefly at the end. If it was a 2-hour course, we probably could have gotten into that. But yeah, I mean, really the pressure that we're most interested in, and I do touch on this at the end, it wasn't really the main focus of the course, was translaminar cribrosive pressure differential. That's really the pressure that's most important. It's the internal eye pressure on the inside of the eye and the cerebral spinal fluid pressure behind the optic nerve, and that's the pressure that the lamina is under. And so if that pressure differential is higher, then the lamina is more apt to change and you're more apt to get cupping. The flip side, of course, is if the cerebrospinal fluid pressure goes up, as it does with brain tumor or space flight, it'll push the optic nerve in the other direction, and the optic nerve swells. So yeah, I mean, I don't know if we'll ever get to a point, or we'll get to a point soon, where we're able to easily measure cerebrospinal fluid pressure in the clinic to get at that, but we know that it's an important parameter.
Hey, Rich, I got a question. I got a history question for you. So this you may or may not know the answer to. Before Goldmann came up with his invention, how was this even measured, or what clinically did people use, or was this just sort of a mystery? Was Goldmann?
Dr. Farkas, you want to answer that one?
Yeah, I mean, come on, man. This is why you're here, right? So maybe you could step in and tell us.
It was something that would look like a plunger.
Yep.
Yeah, so the Shiatsu
tonometer.
And you threw them on their back, and you weren't allowed to use anesthetic in those days, but you snuck it in. You had a
I think I might have
Octane.
used the Shiatsu once. I'm not even sure if I did. And then we had a McKay Mark tonometer.
Yes.
And we had, I know at SUNY around that time, we used that periodically, and the NCT came out. So and then you also had this.
Digital fingers,
right?
Oh, yes.
You had digital tonometry. So yeah, I'm sure there were other ways that we probably don't want to talk about.
Remember, there's a test called tomography, where you have the patient lay down, you put various weights on, and you determine some sort of outflow number. I saw it 2 or 3 times. I never used it, obviously, in practice. But
it would be great if there were a lot of easy devices to use. And in fact, the Falk device that's out there now is measuring tonography. So, that may become something that we start to bring into what we do, because it would be nice to see, let's say, if we add a glaucoma drug and notice that outflow improves, because then we would anticipate also that pressure is going to go down as well. But there may be other ways that, pressure is going down. Maybe the scleral outflow rather than the
But there was no real problem, because basically a lot of people died of broken hearts in their 40s and 50s. So they didn't live too long. So the glaucoma didn't last.
Yeah.
At SUNY, Rich, do you have any trouble prescribing the newer drugs that might be really expensive, Vyzulta, Repressa, et cetera? Do you have to go to the more basic stuff because of the limitations of the Medicaid system, for example?
Sure. It's probably a pretty easy answer.
Yeah.
Like everyone else, the newer drugs, their coverage is different. Their co-pays are higher. So yeah, like everyone else, we are dealing with the same insurance system, and as such, you have to You have to massage the way that you care for your patients. We still always try for what we think is the best approach, but I think at SUNY, when you're in the glaucoma clinic, I don't think it's that much different than it is in private offices. Because again, we prescribe a lot of medication and we're dealing with the same system.
Yeah, well, one question I have: when does an optometrist punt to a specialized ophthalmologist?
Yeah, that's. I think regardless of condition and regardless of whether it's an optometrist, a general ophthalmologist, I think you should practice to what you're comfortable with, and then ask for help when you need it. Now, for me, for instance, I'm fairly comfortable with most adult glaucoma, but I can't put my finger on a laser. I can't use a laser, and I'm not a surgeon. So obviously I'm going to need help there. Most medical cases, I think I can handle well, but there's the occasional case where you're saying, geez, what is going on here? And it's always nice to get another opinion. But I think I'm going down a different rabbit hole here. But as I end my career, one thing I would really like to see is optometrists managing glaucoma further along the spectrum of the disease. We know that 90% of the glaucoma scripts are written by 10% of the optometrists. And we know that I think many optometrists are comfortable with prostaglandins and prescribing initial therapy with a prostaglandin, and then kind of drop away as the disease changes and there's a need for more medications. So I know that wasn't really what you asked. The first part of my answer was, but the second part was a little bit different. So what I'd like to see is optometrists ask for help when they think they need it, but I'd also like to see them get more comfortable, because there's plenty of education out there, get more comfortable in managing medical glaucoma until it's not medical glaucoma anymore. And even then, they should be part of the management. Because like we said before, these patients are with you a long time. They're very comfortable with you. So if you have to send for a laser or even surgery, oftentimes you can bring those patients back.
I totally agree with you, Rich. And that's a problem I think Paul and I always talk about, that we say, thank God for average, because we were both successful because we weren't average. And why? Because I got a great education. Let's face it, you had to learn things as we went because things changed. And they're getting a great education at SUNY, yet still 10% of the scripts. And do the professors profess, hey, come on, what you're just saying, let's treat these people?
Absolutely. As a department chair for clinical education, I know exactly what our students are learning. And I know they have the basic skills to go out there and manage glaucoma. That doesn't mean that you can't, that you have every skill, and you've got to be able to learn. You guys have a great program here, and there's tons of continuing education so that you're able to increase and improve your skills. But as you well know, it's a lot of this is experience, and you can't gain the experience, be it fitting a scleral contact lens, be it doing vision therapy or working with a head trauma patient, or seeing glaucoma patients. You got to see them, and you've got to prescribe for them, and you've got to see what happens in real life. And I think that's where I think I'd love to see more optometrists hang in there for a longer period. This is, again, in most people, it's a slow moving disease. People do go blind from glaucoma, but most don't go blind quick.
Right. And Rich, we're running out of time here, but I want to just give you a plug. So I'm going to put up on the screen for people who can see it at home. I'm going to plug your lecture one more time. So 2 p.m. today, virtual room 3. So Beyond Goldmann Tonometry, Advances in Measuring and Interpreting IOP. So hopefully people will show up and watch. I always love talks like this, right, which are a little bit provocative, right? They're sort of pushing the envelope, and I really like that. So thank you for doing it.
That's exactly right. So thanks. I appreciate it. And again, I will offer my email. It's It'll be in the chat room and at the end of the talk. So if you don't want to add anything to the chat, just send me an email. I'd love to chat about those sorts of things.
Great. All right. Well, Rich, thank you so much for being
Thank you
here.
very
Thanks, guys. Thanks for all you
Thank
do
you.
and what you're doing for education and what you're doing for the profession. Thanks so much.
Thank
Same
you.
to you.
Bye, guys.
Okay.
Oh, that was interesting.
Yep. So
He's known as one of the better professors at SUNY. He always comes up, top of the line in terms of
yeah.
his approach also.
Yeah, his ratings are good. I mean, I can tell you because I collect all of them here, and I always love his talks because they're always interesting, right? It's not just the same old stuff. So something fundamental like this you usually don't get, right? Because I guess Goldmann, for most people who are of a certain age, right, younger folks, this is just it's always been, right? It's just a device that's always existed, and this is how you measure IOP. But I like how he took a broader approach. This isn't the be all end all. So okay,
It's
so
interesting that the Goldmann is only from 1957.
yeah, but for all of us,
Holy.
I mean,
It wasn't available when I was in school.
right. Well, that's the thing. Like for the rest of us, it's sort of like
That's
oxygen,
just
right? Like it's just
yesterday.
always been there. So, oh my God.
Yeah.
1957. No.
Well,
All right, so
I wasn't
guys,
kidding.
guys,
I don't know. I don't know how many people. I graduated from Columbia with the MS degree in 1955. I don't know how many people are still alive.
Do you
I'm a
actually want?
graduating
Do you actually
class.
want to know?
That graduating class. The average graduate then was 22 because it was only a
Right.
3-year course.
Let's look at
But
All right.
it's a
I
lot of
think-
years ago. So unless you have good genes, you're not around anymore.
Yeah.